Hello, I'm John Muir, the coordinator of undergraduate communication skills at Dalhousie University, and with me is Dr. Joan Evans, the director of the clinical skills program at Dalhousie University. And we're here to talk about the communication skills component of the clinical skills program in Med 1 and 2. The communication skills component tends to be front-loaded in the first few weeks of term, with a second intensifying course late, usually in the first term, early second term. The overall structure of it is that we're trying to teach communication skills process up front before the student starts anything else. We then add into that the medical content component, and then later on we ratchet everything up by introducing some additional pieces dealing with emotions, a very brief introduction to breaking bad news, and also expecting students to be able to reflect on their skills and their processes. John?
Yeah, so what we're doing then in the clinical skills unit is front-loading with the communication skills content. And that content then gets woven through the entire unit as students learn physical assessment skills, and will go on to do more focused histories and even clinical skills too in relation to the various body systems.
It's very, very important that the communication skills keep being reinforced by tutors, that it isn't something that we only do on a few set weeks that are labelled communication skills. Those communication skills should be coming through the entire clinical skills program, every interaction with a patient, be it a standardized patient, actor, or be it a volunteer patient, or be it a real patient, needs communication skills to be thought of and looked at and commented on.
Yeah. And you made a good point when you talk about the different patients. In the front loading of communication skills, we only use simulated patients so that the learner has the safest environment in which to learn some basic interviewing skills. And even towards the end of the first term, when we start incorporating emotion and kind of increasing the intensity of the interview context, again, we revert back to a simulated patient, whereas the students have been working with volunteer patients for several weeks before that, as they've been learning physical assessment skills and further history skills.
We choose simulated patients because it is very, very difficult for the students in an interview to hurt the simulated patient. The simulated patient is trained to be able to deal with things that the student may say. If the student says something that might be deeply hurtful and resented by a real patient or a volunteer patient, the simulated patient is trained to be able to isolate that, not take that on personally, and when they come out of character as that patient, wash it away. So it's a very, very safe environment where the student doesn't necessarily have to worry about hurt. They do worry, but they don't have to worry the same way as they might with a real patient, and no real patient suffers.
And the simulated patients are actually trained to give standardized feedback as well, so they are a wonderful learning resource in that interview context. Perhaps what we should also mention as an overview of the communication skills component is that we do use two frameworks at DAL, and we've alluded to them and explained them in more detail in the manual that's online for you. But we do use the Calgary-Cambridge Guide to the Medical Interview, which introduces those process skills, and we've alluded to process skills. Process skills refer to the how-to. How does one most effectively elicit information? Then we introduce the content skills, which is the actual information, the content of the medical history. And the content actually has two different streams if you're looking at a patient-centered clinical approach. And that's the other framework that we use. So the patient-centered clinical method is internationally recognized, as is the Calgary-Cambridge Guide, and used in medical schools across Canada and indeed internationally.
And has very good evidence backing it up as a method for teaching the medical interview.
Exactly, and it's a good way to just break down the skills. If we asked you as clinicians, what are the various tasks of the medical interview? And we both asked these questions in workshops. We get a list about 100 items long. So are you going to teach the student 100 items, or are you going to break it down into 5 or 6 categories and group your items so that students can actually tackle them individually and master a skill? So that makes more pedagogical sense. So that's what we're doing. We're using the Calgary-Cambridge Guide, and we are also using patient-centered clinical method. And what you're going to see in the literature is a focus on the student weaving between a disease and an illness perspective. The disease being the traditional history, all the presenting complaint issues.
Illness is what the patient, however, feels. How does it affect the patient? How do they deal with it? What are their ideas about it? How does it affect their function? And even, what their expectations from this can be, and their worries about it and everything else. Mm-hmm. So it's the same thing, just from a very different perspective. Mm-hmm. But we need to look at both perspectives. Traditionally, physicians have always looked at this from the medical model of disease. And good physicians have realized that the patient's side of this, the illness component, is also very, very important. And how a patient will deal with the advice they're going to get from a physician often deals with how the patient sees it. Some patients may not see that they've got an illness at all, and often that's a big problem because you're trying to treat a patient and you're expecting them to do certain things, and they won't do it because they don't even realize that there's a problem. They don't take it in when you tell them that there's a problem. Because from their point of view, so my blood pressure's high, what does that matter? I don't feel anything, I don't know anything about that. So they have no view of illness here, and therefore they can be very difficult to treat as you think appropriately, because they're thinking, I don't have an illness, I don't need treated.
Yeah.
By weaving these two pieces together, you can get a better understanding, and you can identify when, for example, in that situation, you need to discuss much further with your patient, so the patient does start understanding that there's a problem here that they need to deal with and take preventative measures.
Yeah, so those are the two frameworks that really inform what we do in communication skills teaching. So, and there are ways of approaching that. There's initiating the session, there's information giving, there's organizing the session, and then there's closing the session. And there's also running through those processes. There's always building rapport, and there's always, I think I've just mixed that all up, haven't I? Let's see, John. Yeah. Yes.
Oh, we can't cut this.
Oh, yeah. So, oh, yes. Sorry. I mean, I've done this so many times that I'm starting to imagine it in my sleep. Initiating the session, gathering information, providing structure, building relationship, closing the session. And what we're going to talk about is not explanation and planning at this level in the curriculum. Okay, that comes further in their education when they have something to actually build on. They don't have that clinical knowledge as yet. So that's what our two frameworks look like. And we're going to ask you to read the materials that we've provided so that you have a fairly strong understanding of how you can weave those into your discussions with learners and how you can weave them into all of the clinical skills components, not just the communication skills weeks.
During our process, we also supply students and our tutors with a set of cards. And they come at different times to the students, but usually it's the tutors that come right up front so you know where we're going. And our cards include a card on the Calgary-Cambridge Guide, and it's laid out here, broken down into the various parts. If you look at this, even if you haven't ever heard of the Calgary-Cambridge Guide, you've been brought up in a different system of medical interview. If you look at it, I think it makes fairly good sense to anyone. There's nothing that's suddenly unexpected cropping up in here. The one piece that is there that perhaps some physicians who are a bit longer in the tooth like me may find new is the bit about FIFE, feeling ideas, function expectations, from the patient-centered clinical method. But otherwise, this is very much a classical layout. It's just broken down into individual parts that people can do with it. And that's on one card, and on the back of the card is the full layout of what we expect. And as Joan said, we don't really get into explanation and planning at this stage because you need a lot of knowledge to do that. And the students aren't going to have that knowledge until well into third and fourth years, if then, even into residency. The second card in our system is again Calgary-Cambridge based. It's a breakdown of the relevant parts of the interview. And then it's a whole piece on the functional inquiry. We don't really teach functional inquiry at this point. Again, you need knowledge to be able to use that, so it comes later. But what we've done is we've taken the functional inquiry out of many of the standard textbooks on the medical interview and rewritten them. Why have we rewritten them? We've rewritten them because in the standard textbooks, they're often in medical jargon. So they're written down as, often one-word lines, dyspnea. You ask a patient, do you have dyspnea? You get looked at with blankness. And even some of the students may not know what it is. So we've taken that out and sort of said, have you had any breathlessness? When do you get breathless? Do you get breathless when you lie down? Do you get breathless at night? So again, that can then refer back to, it's PND, paroxysmal nocturnal dyspnea, which is on the charts. So this has been put into patient terms. Simple English, I hope. What we have here is a selection, not a comprehensive guide. It's a selection of the things that are most commonly commented in those textbooks. The students aren't actually expected to use this. They may, however, find it's valuable when they're dealing with some of the patients early on because they really have no great background to ask a lot of questions. There's sometimes one or two questions they can ask. The introduction of this is really much later once they've got knowledge. The students will also get a card, usually later in the first term, on dealing with the angry patient and some of the problems that they have to do and some of the techniques and skills they can use in that situation. They get a card on breaking bad news. And initially we didn't give them this. This was an introduction to clerkship in third year piece. But the students are very, very anxious about having to deal with this and also having to deal with the angry patients. So we give them an introduction to this and also tell them that it will be dealt with in third year so that they're happy. There's another card that we distribute that's usually distributed much later in either in third year in clerkship or even into residency, which is our card on disclosing medical or adverse events.
Actually, we're going to distribute that this year in the professional competencies unit. We've now developed a workshop or a session on disclosing. And so it's not done in this particular unit, but however, students will be exposed to the skill set.
Students have asked about it and again get worried about it. So giving them information up front is very valuable. And our last card at the moment is a card on giving effective feedback, because teaching communication skills is very heavily based on feedback. And so we ask you particularly to look at that card, and your students are taught, they get it in the plenary and they also get it in the card, and hopefully they're going to see it every single session that we do, based on this system.
Yeah, so we use resource cards in the communication skills component. They are available online as well, and learners are going to be getting them as we start to address some of the more complex issues in relation to communication skills. So that talks about the frameworks, our resources. We do have resources in the library if the students and if yourself would like to learn more about the Calgary-Cambridge guide. And we also are looking at the process a little bit then. So let's just talk about that. We do have a couple of lectures which are more skill introduction, skill loading lectures.
There's one right up front before they start, and there's one much later on in the term. They're good sessions. The one up front always gets commented on that the best way to teach communication skills is not necessarily the lecture, and we agree, but there's basic information they have to have. Just giving it an owl, some students never read it. It needs to be done, unfortunately, in a lecture. We don't love that. We've tried to really reduce that. The second lecture we give is one on dealing with emotions in patients, with a little bit about the angry patient and breaking bad news. It's one of the most fun sessions that's given all year in the medical school. We get a lot of comments about it every year because these are really angry patients that they see and real situations. And we haven't held the punches on this one because it's usually done up front with some of our tutors and facilitators who can deal with the problem rather than throwing the students right into it. But so they see things, and they see things that have happened in reality.
And you are invited to attend either one of the plenaries if you would like to come just for information purposes or to see what we do.
We also use a series of tutorials and learning sessions, and things are split between the two. We like to have a tutorial, if possible, up front before any of our LRC sessions where they're actually doing interviews. And so there's one right at the beginning where we introduce the medical history in a tutorial form where it's a smaller group. You're more able to discuss things rather than the lecture, because, as I said, the lecture is not the best way. Many of those tutorials include the use of simulated patients, as we said, so that they can see an interview. We usually like the interview to be done by one of the students because it's more real and it's at the level that they're at. We have sessions in the Learning Resource Centre, which again have a tutorial component usually up front, followed by a set of interviews where the students are in pairs. They get to do one interview, they then observe an interview, then do another interview, and then observe another interview. And at least one of those interviews for each student is going to be done in front of their tutors. And those sort of interact as a sort of the tutorial and the LRC session. Then there's another tutorial on the content of the medical history, and an LRC session dealing with integrating that into the whole process. All of the time we're trying to maintain good communication skills process while integrating new knowledge. And we're hoping that's going to go on even when we're not talking about communication skills, when we're just in clinical skills pieces, because it needs to continuously be reinforced and maintained. Later on, there's going to be a similar sort of session looking at the emotion in patients, again with an LRC session. And there's going to be a set of recordings of the students so they can look at themselves, see themselves, and reflect on their performance. Reflect on what the things that they did well. It's important to reflect on things and give feedback on things that go well as identifying the things that, well, I'm not happy with this, I think I could have done better, and maybe this is what I should try next time. They need to be able to do both. They need to be able to look at the performance and assess it, and as I say, assess it on the positives as well as the negatives.
Great. I think that just about covers it. I think we wanted to just provide a brief introduction to what the communication skills component looks like in the larger clinical skills unit, and a little bit about the processes that we use for teachers and learning.
And for tutors who have not been involved in the first half session, we really would ask you to look at some of the other pieces that we've given, to look at things like the Calgary Cambridge Guide, because we do want to keep using this framework and helping the students along in the framework, and use it as your way of giving them feedback and encouraging them to improve and become great physicians.
Yeah. So each week then we do an orientation session like this that you can actually log on to, and John and I will orient you to what's happening. So again, if you would like to catch up on what's come before you actually started to work with learners, then we would encourage you to go back and view those.
Thank you for your time. We'll speak to you again shortly.